Dr. Veith. My disclosures are the same, but I don't think they impact this. So we know from the randomized trials and the Medicare analyses that EVAR has an early survival advantage that's gone by 2 or 3 years, and then survival is similar afterwards. But reinterventions and ruptures are more common after EVAR. So we wanted to know a couple things. So first we wondered, are we getting any better? Have things improved over time? So we looked at VQI to do this in just elective infrarenal aneurysms. So we excluded anyone with a clamp that was not below the renals, prior aneurysm repairs, symptoms, ruptures, et cetera. Or we excluded anyone who was deemed unsuitable for either EVAR or open. And we looked at time periods. This first time period, 03 to 06, no difference in survival, and these are all propensity matched to make the cohorts similar. No difference in survival from 07 to 10, no difference from 11 to 14, but you see there's things are starting to get better for EVAR. And then in the most recent time period, there actually was a significant survival advantage for EVAR that persisted for 4 years. And didn't seem to be coming together afterwards. So how do we choose EVAR versus open? So I think several people have talked about when you're outside the IFU, things don't go so well for EVAR. But what about large aneurysms? Fabio alluded to this before, but I'll give a little more detail. So we looked at large aneurysms versus small, using 65 millimeters as a cutoff. In EVAR patients, you have much better freedom from reintervention after repairing a smaller aneurysm compared to large, whereas after open repair, there's no difference. Rupture, similarly, freedom from rupture is better in smaller aneurysms with EVAR compared to large aneurysms with EVAR, and as anticipated, no difference after open repair. What about overall survival? Again, better survival after EVAR in smaller aneurysms compared to EVAR in larger aneurysms, whereas open repair had similar survival regardless of the aneurysm diameter. And then a separate propensity-matched analysis comparing EVAR and open among large aneurysms showed better survival with open repair compared to EVAR, but in smaller aneurysms, there was no difference. So large aneurysms probably should go toward open when possible. How about age and comorbid status? So in this study, we broke it down into 3 age groups. And you see this middle group here is where the bulk of patients are. And this is where essentially every single patient enrolled in a randomized trial fits. But we wondered about the extremes of age and how do they compare. And we were able to look at 10-year survival afterwards, comparing EVAR and open. And then we also looked at the interaction based on preoperative characteristics, comorbid conditions, et cetera. So first, the young patients, almost 8,000 of them, 80% got EVAR. Their 10-year survival was better with open surgery by 40%. So young patients, better survival with open repair. That larger group of patients, almost 30,000 in the 65 to 79, 89% got EVAR. 10-year survival was the same, hazard ratio of 0.9, you see. So similar survival for the vast majority of patients, and this goes right along with what we saw in the randomized trials. Now, in the older age group, we had over 10,000 of them, 95% got EVAR. 10-year survival, as anticipated, better with EVAR compared to open. Again, a 40% difference there. We did a cubic spline model because this was not a linear relationship. But once again, this shows that between the ages of 63 and 81, there was no significant difference in 10-year survival after EVAR and open repair. But younger patients do better with open repair if they're less than 62, and those 82 or over do better with EVAR. Then we looked at the interactions, and first in the young patients, again, they do better with open repair, but particularly if you're male or have a large aneurysm or have normal renal function, and we found similar findings as with renal function, the same thing for coronary artery disease and CHF. For the patients in that middle age group, no differences in any subgroup. And for the elderly patients, again, better with EVAR, especially for men, especially with smaller aneurysms, and especially with any comorbidity. So how do we choose? If you don't fit the IFU, you're better off with open repair in all likelihood. Large aneurysm is an unfavorable EVAR anatomic status, and then we saw the impact of age and comorbidity, and we also have to consider compliance, and I'll wrap it up there. Thank you very much for the opportunity to speak.